are you on a tight time schedule or can you go second after Make Believe? She's connecting to audio, so Meg, why don't you call her?
All right, good morning. Good morning. Thank you for having me here. Pleased to be back in this committee room. My name is Meg Fleet. I'm the policy director for the Vermont chapter of the Alzheimer's Association, and I'm here to advocate in support of S302 and act relating to public health outreach programs regarding dementia risk. By 2025, the number of Vermonters over the age of 65 diagnosed with dementia is projected to be 17,000. An astounding 30.8% increase from 2020. In 2022, unpaid family caregivers provided more than 28 million hours of care. That's here in Vermont. Older Vermonters are the fastest demographic growing in our state, and by 2030, 1 in 3 Vermonters will be 60 years or older. 1 in 3 seniors dies with Alzheimer's or another dementia, and S302 will help us meet the growing demand for diagnosis, treatment, care, and support of both those with the disease and their care partners by ensuring information about brain health and dementia is included in education to health providers and the public. So I wanted to share some of the work that we've done in Vermont that's laid the groundwork for this bill and amplifies the need for it. In 2020, the Vermont Department of Health was awarded a 3-year gold building our largest dementia infrastructure grant from the CDC. Grant objectives align with the Healthy Brain Initiative's goals, and they're to increase early detection, support family caregivers, decrease ER visits and avoidable hospitalizations, and reduce risk for dementia. This grant has really helped us increase our capacity by helping us update the state plan on Alzheimer's for the first time in more than a decade, and that helps ensure that our work is aligned, focused, and targeted at areas with the greatest need. S302 is directly out of that objectives, built out of those objectives, and helping us to strengthen the competencies of those delivering healthcare and improving care for populations disproportionately affected by dementia, ensuring messaging that underscores the essential role of caregivers and the importance of maintaining their health, and enhancing public awareness by educating on the benefits of early detection and the link between body and brain health. Other work we've done is to continue our dementia hub and spoke work with the UVM Medical Center, Memory Center at the hub, and primary care providers as the spokes, running the Project Echo Dementia Training Series for primary care providers, adding dementia training modules to my VT Health Learn, which is a free online training resource, supporting the work of the UVM MC Dementia Family Caregiver Center, which has been in the news quite a bit over the past couple of weeks. They officially launched publicly after almost 2 years of developing. Researching and launching the UCLA Dementia Care Model at the UVM Medical Center Memory Center, that's just starting now, and creating a dementia resource guide for providers to share when they make a diagnosis. You in this building have helped us meet some of these goals by hearing the struggles faced by families touched by dementia, adding to Vermont statutes requirements for public education resources around dementia, and supporting our request for a statewide dementia service coordinator. We welcomed Tiffany Smith to that position last week. Last fall, the Department of Health was awarded a second round of gold funding, allowing us to continue to build our dementia infrastructure for another 5 years. This bill is central to the work we are focusing on with this round of funding and will ensure we utilize all existing opportunities to educate providers and the public about brain health and ways to reduce the risk of dementia. According to the Healthy Brain Initiative, an aggressive public health effort to reduce the prevalence of risk factors such as high blood pressure could result in an estimated 1.2 million fewer Americans with Alzheimer's in 2050. Vermont has a high prevalence of 3 health conditions that increase risk for cognitive decline. 38.7% report physical inactivity, 35.2% experience midlife hypertension, and 34% of Vermonters experience midlife obesity. So this bill specifically calls out education as part of existing and relevant public health outreach programs. That's in section 1B. And this means that when health professionals are learning about the diagnosis of hypertension, they're learning about its connection to brain health and dementia risk. And when they're talking to their patients about hypertension, they're going to mention that addressing that can also decrease the risk for dementia. Or if they're talking about addressing the benefits of physical activity in a public health campaign that's already run, it would mention that being active can reduce your risk for dementia. The wording we chose in this bill also aligns with our new Age Strong Vermont 10-year multi-sector plan on aging, with the goal of helping Vermonters age well by reducing comorbidities. In section A, educating health profession providers, I wanted to emphasize a couple pieces. The first section where it talks about the value of early detection and timely diagnosis. Early detection and diagnosis of this progressive cognitive disease allows individuals and their families time to plan and to build caregiving support capacity. This will result in less stress on many of our systems of care. And I mean, situations also, if you know someone's declining, you have time to build an in-law apartment at your house. You have time for a family member to relocate to help with caregiving. If you find out at the moment that you need the services, you don't have the capacity to figure out as an individual how you can address this, and more of the burden ends up falling on the state and on one person who's then overburdened. In section 2, it says the detection of younger onset Alzheimer's. And I like that that's specifically called out. I know you've had Pamela Smith from East Middlebury here in the past, and you probably recall her stories of multiple years of misdiagnosis. Those living with younger onset Alzheimer's face even greater struggles, including leaving the workforce and loss of that income, caring for children, spouses who are working and not able to support them in their caregiving role. And in section 4, the significance of recognizing the care partner as part of the healthcare team is important because it aligns with new national dementia care model that's being rolled out by the Centers for Medicare and Medicaid Services, CMS. They rolled out the guide model earlier this year, and they're testing it for the next 8 years. And it includes the caregiver and their health together with the individual with dementia as one group. And hoping that they can reduce the stress on caregivers and their negative health outcomes by addressing it right at the get-go. So we did want to highlight that Vermont's dementia caregivers are struggling. 35.4% report depression, and the national average for dementia caregivers is 24.4%, so significantly higher. And 66% have one or more chronic health conditions compared to the national average of 64%. I like that this bill also targets campaigns to those at higher risk, including Black and Hispanic populations and women. The Alzheimer's Organization, as well as so many other organizations and agencies, are publicly raising awareness, creating programs, and supporting Vermonters with all types of dementia and their families. S302 is supported by AARP Vermont, the Governor's Commission on ADRD, Healthcare Advocate at Vermont Legal Aid, UVMMC Dementia Family Caregiver Center, the Association of Adult Day Services, the Association of Area Agencies on Aging, and the Vermont Ombudsman Project. Thank you for your time and your commitment to Vermonters with Alzheimer's and all other dementias. And I attached to my testimony the facts and figures and the risk factors from the Center of Excellence with the data on Vermont.
Thank you. And we have your testimony on our webpage. That's very helpful. Have the links. And go ahead and send the links.
Thanks for your testimony. You have a lot to digest there, but there was one term you use I'm not familiar with. What is comorbidity risk?
Yeah, so many Vermonters have comorbidities. That could mean you have dementia, and imagine you have diabetes as well. You're trying to remember to take your insulin shot, but you don't have short-term memory. So most people with dementia have another comorbidity as well of some kind. And most care partners have multiple comorbidities of their own because they tend to be older. So they may also have hypertension, they may also have diabetes or another risk factor.
Any other questions for Meg? Okay,
Thank you so much.
thank you. Thanks for all your work on this. So Mary Claire, are you on a time, do you have a time crunch? Go ahead. You're muted.
Yeah, I just noticed that. I'm not, Senator, so if there's someone but ahead of me, you're fine. I've got a half hour booked.
Okay, so why don't you go ahead and then we'll go to
Okay.
Crystal. Is it Crystal?
Christelle.
Christelle.
Thank you, Senator. I'm Mary Claire Carroll, a resident of Richmond, and I'm testifying in support of the S302, an act relating to public health outreach programs regarding dementia risk. I'm here to speak To Section A of the bill, the importance of educating medical providers. My older sister was diagnosed with Alzheimer's in January 2020. As upsetting as the diagnosis was, it was more upsetting to her partner. What was more upsetting to her partner and I was the length of time it took to receive a definitive diagnosis. My sister lived in New York City. She had great medical care from NYU Medical Center, 2 blocks from her home. But it took her partner and I a couple of years to convince her primary care physician that they should refer her to an Alzheimer's dementia specialist for assessment. In her late 70s, my sister, a journalist and a teacher with a vibrant personality, had begun to show signs of confusion and memory loss. Her partner and I saw the changes, but my sister hit a decline so well that no one but family members saw it. Because her primary doctor did not immediately notice the cognitive changes, he questioned our desire for some sort of cognitive assessment. Without the assessment, my sister was not eligible and could not access programs that might have helped her. And her partner could not access programs for respite care or support. Finally, after 2 years, her partner badgering her physicians, we had an appointment at the Barlow Center, which is NYU's Dementia and Alzheimer's Center. She was given some cognitive tests and then scheduled for further tests. And as a slight sidebar here, she was given something called a mini cog test, which is a series, and I believe Megan actually might have added that to your information on testimony. But it's basically the provider recites 3 words to the person, and you're asked to recite those back. And they're given 3 times to do that. Then they're asked to draw a clock with the hands, with the numbers, and set it to, I think it's something like 10 to 11. And then they're asked to repeat the words back, the original words back to the provider. And that's a real quick mini cognitive test. And that's what my sister was put through for the first visit to this Barlow Center. She was scheduled for further testing. The early test confirmed our fears that something was wrong. Almost immediately, she was signed up for programs to help her learn coping and communication skills. She was signed up for physical therapy. She was signed up for exercise programs and nutrition programs. And just as important, her partner suddenly had access to lots of information and support, including one-on-one counseling, which she still uses today. Almost a year after her diagnosis, my sister ended up in a long-term care facility in our hometown in the Adirondacks, thanks to a broken hip and COVID. I can't help but think, had she been diagnosed even a year earlier, she would have had better quality of life and more time receiving the support she needed. My experience with my sister made me realize how important early detection and early supports are for someone diagnosed with Alzheimer's or dementia and for their caregivers. What a difference it would have made if our healthcare providers had some sort of testing protocol or information that would have provided early clues to her cognitive decline. My sister's experience in New York is not different from the experiences I hear from many in Vermont. I believe that healthcare professionals had the tools and information and clearly understood the harm being done by postponing diagnosis. They would be better equipped to detect dementia. And if I may, I would also like to speak to Section A3, the importance of Medicare annual visits to screen for Alzheimer's and dementia. I must admit that I had assumed that during my Medicare annual exam, there would be questions or simple testing that would give my providers and myself a baseline from which I could base my own care decisions. I'm a sister of an Alzheimer's patient, and I'm a daughter of a dementia patient, my dad, who died some 30 years ago. Clearly, I'm a candidate for early testing. I was surprised. My PA checked in and asked questions about other diseases in my family history, but didn't even acknowledge dementia or the possibility of it, except to ask how my sister was doing. I only realized this oversight as I reflected on the visit and also realized how important it is for me to know my brain is functioning as it should be. This was a missed opportunity for me, my family, and for the state, because we know waiting until there's a crisis is the most costly and challenging time to address a medical need. I know changing wording will make all the systems operate perfectly, but I strongly believe focusing attention on educating and preparing medical professionals to better diagnose and support those with dementia is important. Vermont's done a great job educating our community and health providers about the benefits of early detection on so many diseases. I'm happy the passage of S302 would increase public understanding and perhaps take away the stigma of the disease of dementia and Alzheimer's. While dementia is not an important part of aging, risk does increase with age. Thank you for taking up for the bill. Thank you for listening to me and helping Vermont build a better framework to address Alzheimer's and other dementias. Thank you.
Well, thank you for your testimony. That is very compelling testimony. We appreciate it. Other questions from Claire? No questions at this time, and good luck with your sister.
Thank you, Senator. Appreciate that. Take care.
Thank you, Mary Claire.
Thank you.
So, we'll just move on to John Belton. You're here. Thank you for being here. I
Thank
see you
you.
have your purple on.
I do have my purple on. You
That's
betcha.
cool scarf. Yeah, they have
Oh,
shimmer. Yeah, look at that. It's almost like fractals.
you can't have it,
We all want it.
right? My name's John Boughton. I'm a 73-year-old retired county forester. I live in Hartford. You may remember that Judy and I testified before you last April in support of the state dementia coordinator position. It's just been filled. Thank you. Judy would be here if she could, but she died in September. Health problems brought on by Alzheimer's, and I'm wearing a scarf in her memory. Judy was a colorful, lifelong learner who was drawn to activism. She wanted us to support the Alzheimer's Association missions. We walk for Alzheimer's. We attend Alzheimer's awareness days here in the Capitol and testify here. Now I'm volunteering as an Alzheimer's Association ambassador in hopes that sharing experiences from our last 2 years helps others. Tomorrow, Judy Scarf and I will be introducing an Alzheimer's Association program on communications in Whitewood Junction's Bugbee Center. We are working to destigmatize and make it easier to talk about dementia. Today, I'm testifying in support of S302, an act related to public health outreach programs regarding dementia risk. I'm going to recount some things that could have done better if I know more. This bill will help by charging state of Vermont departments to 1, increase public awareness about early signs of dementia, and 2, publicize the importance of identifying and diagnosing Alzheimer's and other forms of dementia in the early stages. This will especially help those 50, 60, 70-year-olds who, as they age, are more likely to show symptoms. Ever since Judy's dad died with Alzheimer's, she worried that she might be predisposed. Shortly after she retired in 2016, she worried that something might be wrong. I thought it was her imagination. She got a referral, but it would be a long time before there would be an open. To me, that kind of meant that there was no urgency. She got a telehealth appointment early in the pandemic. And the day of the appointment, Judy never set up her computer and she missed it. We had each always handled our own healthcare, so I figured she was just not interested enough to put the energy into completing the work that needed to turn that thing on. Honestly, just irritated me that she wasn't taking care of business. Our PCD followed up when she didn't get a report and made another referral. This time we visited the doctor together. It was a shock when I saw that Judy could not complete most of the problems on the cognition test. My irritation at her behavior shifted instantly to understanding, empathy, and resignation. Her irritating behavior was not her fault. The doctor's diagnosis was early stage dementia, probably Alzheimer's. She provided counsel, reading materials, a prescription, and follow-up referrals with a member of the team. The diagnosis and treatment program put us on a whole new, less destructive pathway. How does this relate to S302? Section B charges state departments with increasing public understanding and awareness of the warning signs and the benefits of early detection and timely diagnosis. They know that so far, there's no cure, no way to reverse the damage caused by Alzheimer's. The drugs that came on the market only this last year are only available to folks in the very early stages, and they slow, but they do not stop the decline. Therefore, recognizing signs and getting tested and diagnosing Alzheimer's in the early stages is essential for good treatment care. My perceptions of events leading up to her diagnosis were just plain wrong. I misinterpreted their events. It was not all of her imagination. The long wait for the appointment was not because it wasn't important. And Judy missing the telehealth appointment was not due to lack of interest on her part. Neither Judy, I, nor our friends knew enough to look out for the signs of Alzheimer's and other dementias. We didn't know what those signs might be. If we'd known, we could have gotten a diagnosis and family support that comes with it sooner. Even though it's too late for Judy, there are thousands of Vermonters who might not know that there are the early stages, of Alzheimer's or the dementias. Knowing about and getting treatment early on is key to a longer, healthier lives. It gives precious time for enjoying life with family and friends. Please support S302. Increasing public outreach can dramatically improve the lives of Vermonters who will develop Alzheimer's and other dementias as they age. Thank you for listening.
Thank you, and I'm very sorry for your loss. I do remember when you were both here last year.
We have a picture, the whole
Yeah.
committee, we do with everyone.
Everyone,
Yeah. So sorry.
thank you. And thanks for your continued interest and work on this issue.
So thank you for
Yeah.
the work that you guys do. It's very important. And volunteer for sure.
And Christelle, welcome. Sanofi.
Yeah.
Did I say that?
You did say that.
Okay, welcome.
Thank you. Good morning, everyone.
Have you been in this committee before?
I have.
I thought
I have.
you said it wrong the last time.
Yeah. Yeah. So you can sit again.
Good.
Hi, everyone. My name is Christelle Sanofi. I am from Williston. I am a senior studying public health sciences at the University of Vermont. I discovered Alzheimer's Association through an internship course provided by my college. Today, I will be testifying in support of S302 and act relating to public health outreach programs regarding dementia risk. I want to touch on how a lack of cultural relevance, health literacy, and patient-provided care communication has shown up in homeless communities in Vermont. My parents are from the Congo and came here about 22 years ago and had me. While they worked hard to fully integrate into the language and culture, it wasn't always like this. In my younger years, I was frequently translated to them in school appointments, doctor's appointments, and grocery stores. While this might appear typical for immigrant children, my studies in public health have enlightened me to the burden it places on the child. It's essential to clarify that the issue isn't encountering individuals who don't speak English. The issue is rather the lack of supportive systems and programs that could streamline these daily processes for them. At a young age, I had to explain to my mother, to explain to her physician how much pain she's feeling on the smiley face scale. Now that I am 21 and immersed in the healthcare field, I often think of what it would be like for a child to have to explain to her doctor why her mother is experiencing forgetful or peculiar behavior. This bill advocates for an increased public understanding and awareness of the early warning signs of Alzheimer's disease and other types of dementia. It also pleads for uniform, consistent guidance in non-clinical terms with emphasis on cultural relevancy and health literacy. In this instance, this will be demonstrated by having a translator position in French or Lingala, the lead spoken Congolese communities, and by ensuring that healthcare services are provided with cultural sensitivity, considering the unique background and customs of my culture. In an ideal scenario, the appointment would conclude with the physician and translator collaborating to communicate information about my mother's health in a manner that she can easily understand. Additionally, they would facilitate connections with networks of skilled volunteers or community health workers from the Congo who could offer reliable guidance and support within their own communities. Solely relying on newsletters, emails, or health campaigns isn't sufficient for effectively disseminating information. Simply having information available doesn't guarantee that it will be absorbed. These communities require personalized, customized communication. Storytelling, like the one we just heard from John, proves to be a powerful method for conveying messages, mirroring how my mother and many other adults, but my community impart lessons to younger generations. After attending my doctor appointments and undergoing tests, I anticipate receiving the results via the MyChart website. However, each time the results arrive, I find myself unable to comprehend them. Despite having excelled in my medical technology course, I'm struck by the complexity of the information presented. Even after attempting to search online for clarification, I'm often left with more questions than originally I had. And feeling frustrated and discouraged, I eventually chose to ignore the results, assuming that if they were serious, they would call. They did turn out to be serious, and no, I never received a phone call. Unfortunately, this is a common experience for many patients. Providing easily understandable language is not only empowering and potentially life-saving for these patients, but also fosters a sense of self-autonomy, enabling individuals to understand their health status and make informed decisions about their care. Data from the CDC shows that the prevalence of Alzheimer's among Black Americans over 65 is notably higher than among their white counterparts. With diagnostic discrepancies further complicating the picture, this statistic hit home when my grandmother passed from dementia on August 14, 2023. As a student, it wasn't until this admission that I realized studying outside the states didn't necessarily encompass education in brain health or dementia. I didn't really remember video calls where she struggled to recognize my mother or engage in unusual behavior. Just a week prior, she was her usual self, talking, laughing, and singing church hymns. The sudden transformation baffled me, highlighting the urgent need for comprehensive education on brain health and dementia. To endorse this bill is to advocate for equitable access to vital information on brain health, regardless of language or community background. Let us stand in solidarity with all Vermonters affected by Alzheimer's/dementia, striving for a healthcare system that serves everyone affected. Thank you all for your attention to this critical matter and the opportunity to enhance healthcare.
Thank you for your work on this and your family.
Sorry about your grant. Thank you.
Yes. Questions? Thank you for both of you. Thank you for your testimony.
I live in Burlington. We have embedded in our school district multilingual liaisons who work with students, but also liaise with families outside of school. Do we have that kind of outreach in the medical system? Do you know, multilingual liaisons, I guess is what they would be called? So are there folks embedded in our healthcare system that can directly work with families who might be masters of other languages and cultures?
I do know that the community health center, when you Burlington, that neighborhood, there are some volunteers. I know I have been asked to volunteer and I have helped families out in the past. I mentioned French and Lingala in my testimony, but Congo, there are many languages along with like mother tongue that I know I can speak. Like Swahili, usually a lot of people speak Swahili, but not enough people speak Lingala or French. And so there are those health centers and they're all volunteers, but not enough people who speak all languages necessary to be able to fully help these parents.
So maybe a family member who does speak English can go. Oh,
Maybe, but then to have them,
that's difficult.
yeah, also understand what they're speaking, you know, I need to understand what I'm, like, you know, me, a healthcare student, who I feel like is pretty proficient enough, you know, be able to understand what I'm reading, to then be able to translate it and explain it to another individual in a way that they can understand.
Does this work through the dialects that you're talking about, the languages that you're talking about?
So Lingala just recently, I'm talking about,
Okay.
so just on Google, but even then, it doesn't correctly translate what I'm saying.
I didn't understand, yeah.
Yes.
So, I'm looking over at Brandon from the Department of Health. Do you have any information different from?
You know, it's the President Abbott, Department of Health Policy Director. It's not something I can speak to intimately, but I'm happy to look into it and provide the committee. with
That'd be
some
terrific,
information.
yeah, good. Senator Hardy.
Thank you, Madam Chair. Thank you, Christelle, for your testimony. I'm looking at the bill because, I want to make sure that the complications that you're bringing up with translation and cultural, understanding
Is
is
included.
included in the bills sufficiently. So do you feel like it is?
If you want to speak more to this,
Maybe what we could do would be to look at the bill with Katie. And then while we're doing that, Christelle, you might want to also look at the bill if you do, because
I have, yes, I,
Go ahead.
the part I have pulled up
Yeah,
is part where I think it's section I, sorry, the part where you click, if you don't get the bill, if you click Control-5, Control-F. Sorry.
go ahead.
Control-F, and then
Of what page you on? What are you on?
I think it's section 2 at the very end. The
Right
last
at the
section.
very end.
yes, 5, I,
Okay, population.
where, yes,
Fine.
where it says consistent guidance in non-clinical terms with an emphasis on cultural relevancy and health literacy. So going back to your question, Madam Chair, with the me being able to translate for somebody, but also being like educated on what I'm saying. I can tell them what the doctor is telling me, but I might not even understand what the doctor's telling me, but I'm just like saying it, you know? So,
Yeah, it seems to me that we might wanna
We can think of-
strengthen this a little bit because it doesn't really mention language. It talks about cultural relevancy and health literacy. But it doesn't really talk about the situation that you were in with trying to translate for your mom.
Let me ask a different question, but related, and that is, what if anything will happen with regard to language if this bill is passed? Will you, as part of outreach, inform PCPs about access to translators or others with linguistic skills that they might encounter?
I believe the question might be better suited for someone else, but I believe that Vermont has 9 languages that they officially support, and I would hope that those people would also be educated on this kind of information and be able to be of support, but I don't know exactly how that flow works.
Back to you.
Yes, so I can tell you that the department does have an ongoing translation initiative across really all of our educational and outreach materials to see how we can expand translations as broadly as possible, even beyond just those 9. I think it's fair to say this would be included in that as well. I can't speak right now to the prioritization or the kind of where they're at with that translation process now, but I think it could be something that we would certainly be interested in doing and that we could as well.
And also think about what we can put in the bill that ensures that that's happening. That would be helpful. And then I see, Rebecca has her hand on the comment on this, so for the record, go ahead.
Madam Chair, Rebecca Silverdale, Control System at Vail. I suggest,
Can you speak up just a tad?
the folks at Racial Equity might be able to really address the language. I know that's one of the things that are doing that right now, through their lens. So it's just one side.
Okay, well, I mean, for us, it's a matter of ensuring that it's included in the outreach that goes on. But probably doesn't matter as much who's doing it, because that would be part of the Department of Health or Alzheimer's Association process. Senator Hardy.
Thank you. Because I think it's not just about the outreach that the Department of Health is doing. I mean, it's more actually about the medical providers themselves. I'm actually looking on the University of Vermont Health Network to see, because I think your point, Senator, about the schools having these cultural liaisons, excuse me, do the hospitals have cultural liaisons? Does the UVM Medical Center have cultural liaisons that patients can access in order to help them with these appointments? Regardless, whether it's Alzheimer's or cancer or birthing or whatever it is, so that kids and family members aren't put into the position of having to do it all the time. There's so many instances of young children having to,
We did have
translate things
cultural-
that are really not appropriate for little kids to translate.
We did have a cultural liaison, from the University of Vermont Children's Hospital, yes. Years ago.
Yeah,
But so I don't know that we can direct the UVM to do that in this bill, but we certainly can have the communication with physicians and medical providers. That is important.
yeah, they don't have anything that's jumping out to me on their website about this being available, so.
We'll,
Something for us to think about, because it is.
it is, I know, whether this bill will solve all the problems, I'm not
Right,
sure.
right.
Yeah. Every time you do one thing, you find 2,400 hits with other things you need to do. Christelle, thank you. Any other questions for Christelle? So the issue around language is something that we have here, and then ensuring that the providers involved and engaged in the bill. That does include, yeah, understand the need for cultural and linguistic skills. Thank you.
Thank you, Madam Chair, for your great questions.
Yeah,
Thank you.
okay. Okay, we have 5 minutes. Why don't we just look at the bill briefly, and then think about what we might need to do further. You've heard the conversation? So if we can look at 302 and then move on, we'll take a quick break and move on to 192.
This was sent to Kiki, so it should be all set.
All right.
Mini cough. Thank you,
You
Mike.
can keep that one.
You want to keep this too?
Yeah. Whoever reports the bill, then have a copy of it to test. Thank you. I was gonna do that. In this committee, there was a terrific New York Times article a couple weeks ago about Alzheimer's. And I was gonna give everyone the memory test. That was not. Oh, well. Welcome.
Thank you. Katie McGlynn, Office of Legislative Counsel. So this is S 302. We've walked through it on previous
We
occasions.
did.
I can go through it again and
I think the question is with regard to that last section on, well, go through it, it's very short.
okay, the last section is specific to sort of the information and guidance that the departments are providing. And it's not for obligation on providers. So in subsection B, you're directing the departments of health, mental health, and Dale in consultation with the Commission on Alzheimer's disease and related disorders and other relevant work groups and community organizations. As part of existing and relevant public health outreach programs to educate healthcare providers regarding, and then we have a list that's specific to education for healthcare providers. The value of early detection and timely diagnosis of Alzheimer's disease and other types of dementia. Validated assessment tools for the detection and diagnosis of Alzheimer's disease and younger onset Alzheimer's disease and other types of dementia. Benefits of Medicare annual wellness visit or other annual physical for an adult 65 years of age or older to screen for Alzheimer's disease and other types of dementia. The significance of recognizing the family care partner as part of the healthcare team. And the Medicare planning billing code for individuals with Alzheimer's disease and other types of dementia. So that is specific to providers.
Question, the sphere of healthcare providers. What would that include?
It's pretty vague and we don't have a cross-reference here. If you wanted a specific list, we have places in statute where we define providers. Or you could define providers specific to this section. And it would be as broad or as not broad as you want it to be. It could be physicians, it could be nursing staff, hospitals. You could have it include entities like a hospital.
So the list of initiatives is completely appropriate, but I'm wondering what the mechanism is. The second, education and awareness, that kind of detail is lacking. Not quite sure who can articulate what the bill would really do as opposed to what its lofty goals are. How do you actually recognize this?
Who's doing what? So it's the Department of Mental Health. It's all those departments in the way that they currently provide outreach. So then the question is, how is current outreach done?
How was it done and
Yeah.
how has it changed?
Yeah, that's the question. So
Looking back over the existing language to see how that was worded, and that just directs Dale and Health Department. That language is to develop and maintain easily accessible electronic print and in-person public education materials. So a little more detail on that section. Don't know if that would be appropriate in the same way for this section, but that is what you have currently in statute.
Thank you.
yeah, that might be helpful.
And then in subsection B, this is the department's responsibility with regard to the public. So increase public understanding and awareness of the early warning signs of Alzheimer's disease and other types of dementia. The benefits of early detection and timely diagnosis. And then specific to the departments and their public health outreach programs pertaining to Alzheimer's and other types of dementia, the departments are to provide uniform, consistent guidance in non-clinical terms with an emphasis on cultural relevancy and health literacy, specifically targeting populations at higher risk for dementia, for developing dementia.
Okay, but that's for the public.
Yeah, public health.
So then looking at what is provided to, lost myself.
Providers and public.
Yeah, that's for the public. Then educate healthcare providers. Is there anything in there about cultural or language? Because as we heard that could be a problem at the provider. So with the public, it's one thing, but with providers,
I'm also just questioning the word relevancy, and I may not understand what it really means, but it just seems like cultural understanding would be better. Because I mean, of course, it's relevant, it's health,
yeah,
right?
Yeah.
So, I don't know.
understanding.
Either
Okay,
understanding or
Christelle.
sensitive, so sorry. The term is fluency. People use the word fluency. Cultural fluency, yes.
That's a better, okay, do that. And then what about, this, now we're talking here in two places. We're talking in educating the public, we're also talking in, connecting with providers. We want to add something here about, cultural fluency, perhaps language or linguistic needs, skills. See. Oh, okay. Go ahead.
Okay, I was gonna suggest that under in section in A, where we have a whole list. Perhaps it's that we add on one of the little eyes.
6,
About the value or the necessity or the something of providing,
was this culturally fluid?
language translation, just, language translation and, cultural whatever, for patients themselves. So that, if there's a situation, because I think doctors might not always think of it, and if.
But if you're asking the provider to provide that information, it's then, or be culturally fluent, then it enables the individual provider to support the patient. So the community, the second part, where the patient is part of the community, is understanding what that means, and then, so.
Right, no, but this is just saying educate healthcare providers regarding these things.
Yes.
And one of the things we can educate them is the value of ensuring that patients have necessary language translators available. So that it's not putting it on the healthcare provider to know how to speak French or whatever, but it is saying to them, hey, maybe we should think about getting a translator for this patient because I know this patient isn't fluent in English. Do you know what I mean?
Right, yes, the other piece of that is the cultural fluency. I thought we would do both of those.
Oh, yeah, we could do both.
So I think we
Put
need,
both of them in
I don't
there.
know if we put them all under 6 or
I
7.
I wanna agree with my colleague, because I think having that human element is extremely important.
Absolutely.
In healthcare as it is in education, and being able to answer questions and have a conversation is critical, not just, you know, having a translator, but a human being engaging in the conversation.
You know, and sometimes it might be relegated to Google, which isn't there yet, but
Not even close.
see what happens.
A poor substitute.
Katie, is that making sense?
It is, I'm trying to pull up what the health equity. I wanna see what language they used,
Okay.
not because we couldn't choose different language, but I sometimes, I mean,
It's nice to be in synchrony.
yeah, and
Yeah.
I think it was cultural relevancy, so
Ah.
that's why I'm sort of hesitating, I'm trying to remember what we did there, that's what they say.
Okay, that's too bad. So,
I mean, you could change it in both places, you could use different language, that's your choice. Let's see what it says. Cultural competency. Cultural humility. Cultural competency means a set of integrated attitudes, knowledge, and skills that enables a healthcare professional to be effective, to care effectively for patients from cultures, groups, and communities other than that of the healthcare professional. At a minimum, cultural competency should include the following: awareness and acknowledgement of the healthcare professional's own culture, utilization of cultural information to establish therapeutic relationships, eliciting and incorporating pertinent cultural data in diagnosis and treatment, understanding and applying cultural and ethnic data to the process of clinical care, and the ability to recognize the importance of communication, language fluency, and interpretation in the provision of healthcare services, and assist with access to interpretation and appropriate communication services.
Can we cross-reference that?
Yeah, so what do we have? The cultural relevancy.
Yeah,
So maybe an emphasis on cultural competency as defined in.
right. Because we did work hard on that. Meg,
Oh, thank you, Madam
for
Chair.
the record.
Meg Lee from the Alzheimer's Association. I just want to re-emphasize what Senator Hardy was saying in that the section 2 is about the education to the public.
Yeah,
And I do believe that it would be important to call this out in the section specifically to healthcare providers, maybe addressing the population, risk factors and populations at higher risk and the cultural relevancy the same way it is
right,
below, not that they don't know,
right.
but that they're aware when people come in and say, I'm of higher risk.
That's exactly what we're doing
Okay,
right now.
great.
That's why I asked to have whether we want to put it under 2 separate sections
Ah.
of language or competency, or put them together, so it seems like separate
Could we,
based on this definition. Yes, go
could
ahead.
we, looking at 2, could we just change the lead-in language? And there, I mean, oh, you want it
Okay.
to be for providers too? Well,
Yes,
this is educating providers and it's the departments.
We want both.
I don't know, I'm just wondering if we could just say in subdivision two, and their program, their public health outreach program and programming to providers, the department shall.
Okay, could try that. Let's look at that. Why don't we do this? We've had a good discussion here. Is there anything else we want to address within the bill today? And then what we could do is ask Katie to come back with some revised language for us the next time we look at the bill. So we can move along with it. That makes sense, right? Anything else we want to do here today?
For here today, no, but for future testimony in this bill, can we have those various agencies that were highlighted in the bill to come in and talk about what they do now and then how they would.
So we have Department of Mental Health, Aging and Disabilities, Dale, and then Department of Health, so
Mental health.
mental health, so those, well, yeah, we can do that next time we have the bill.
In that type of scenario, do they typically have like a lead agency, or are they all just kind of?
Department of Health, I think, is the lead agency on this. Yeah. So we'll have them in the next time, we'll have Katie's language and, we'll try to get that posted up so folks can look at it or send it out. And we get Dale, DMH. Who else? You.
BH.
Okay, so. And then the Commission on Alzheimer's has already spoken. That's good. Anything else that we want to address in the bill, or you think you'd like to make changes to today?
Did you list the racialized observation, racial equity and we were talking about?
We didn't, but we can have them in. They're not listed in the bill.
No, just, I mean, on the line.
Yeah.
I mean, whatever.
Yeah, we should probably put them somewhere in the bill. Is what I'm thinking.
Or just have them look at the language we just talked to.
I
Katie
would
about.
like to have them come in, but I'd also like to have them in the bill because they're obligated to do some of this work. So, to work with the commission. Yes, Rebecca.
Chair, thank you. Rebecca Silvernail, and I did let ORA know and they're reviewing the testimony and so.
Oh, good.
They're,
Terrific,
they'll
thank you.
contact you, but just to be sure,
Just have them connect with Kiki and.
I will do that.
Yeah, connect with Kiki, yeah.
Yeah, just
Okay.
now I know.
All right, so that'll be some good improvements, I think, to the bill. It's a good bill to begin with. We'll make it gooder. Okay. All right. Anything else? Okay, so I'm gonna suggest we take a 5-minute break, short break, and then we'll come back to S-192 and go through some technical corrections and some corrections that Katie has put up